So as mentioned, I'm going to talk a bit about my research, but also some rather exciting future potential directions in interventional image-guided interventions with this work. So just a quick outline for my presentation. I intend to motivate breast cancer screening and definitive diagnosis and define the clinical challenge in increased risk populations, including those with dense breasts and also underserved and vulnerable populations. Then I'll describe an alternative wearable whole breast 3D ultrasound system for point-of-care breast cancer screening, and also a 3D complementary breast ultrasound approach to improve spatial resolution. And finally, just discuss some potential avenues for whole breast ultrasound-guided image-guided needle interventions. So breast cancer, as we may know, is the most commonly diagnosed cancer in women, with over 2.3 million women diagnosed in 2020 alone. And this represents a lifetime risk of 1 out of 8 women. And although breast cancer has a very high incidence, it has a relatively favorable survival. And this can be attributed to the detection of these small, early stage breast cancers due to screening. And these breast cancers often have more treatment and also interventional options and an overall improved prognostic outcome. So successful intervention of breast cancer is reliant on first its early detection with very sensitive and specific screening methods with the aim to detect breast cancer in asymptomatic women. Then diagnostic imaging and also image-guided needle biopsy methods are used to accurately localize and spatially sample these breast lesions for definitive diagnosis. Importantly, breast cancer is a very heterogeneous disease with different spatial regions, with various stages and histopathology, which ultimately determines its treatment options, its intervention, and that prognostic outcome. So breast cancer screening typically starts with mammography, but despite its effective mortality risk reduction, it is still limited in women with dense breasts. Breast density has a masking effect of suspicious breast lesions as they both appear white on a mammogram, and this reduces its conspicuity relative to normal breast tissues and decreases that overall sensitivity to detect breast cancer. Additionally, breast density itself is a very strong independent risk factor for developing breast cancer, and this impacts approximately 40% of all women. So beyond breast density that impacts this substantial proportion of women, there are also several complex interrelated factors and also different healthcare disparities that contribute to increased risk for breast cancer. So specifically, very well-known factors such as age and assigned female at birth, non-modifiable factors such as genetic predispositions or reproductive and hormonal factors, to modifiable and lifestyle factors that ranging from diet to alcohol consumption may increase that overall risk. Importantly, there are also several healthcare disparities and inequities that result in a disproportionate increase in breast cancer-related incidents and also mortalities in these several underserved and vulnerable populations. And these inequities stem from things like marginalization in race, ethnicity, gender, and sexual orientation, but also social determinants of health from socioeconomic status to environmental factors. And these ultimately reduce inclusivity to healthcare practices. They limit accessibility and they impose different health cost constraints to accessing very high quality patient-centered care. So therefore, there really is a clinical challenge to improve both early detection and definitive diagnosis of breast cancers in these increased risk populations, including both those with dense breasts and also underserved and vulnerable populations. And this would intuitively open up really exciting avenues for more interventional and treatment approaches. So the central objective, therefore, of my research was really to develop and validate an alternative, cost-effective, robust, and high-resolution method for point-of-care breast cancer screening and also image-guided needle interventions. And this objective directly stems from this unmet clinical need for accurate early detection and definitive diagnosis with these increased risk populations. So how exactly do we achieve this objective? And this really necessitates a very strategic integration of 3 essential components that fall within this breast cancer paradigm. So first, employing dedicated imaging modalities for effective early detection and localization of breast cancers, independent of breast tissue density. It also involves developing mechatronics or automated approaches for accurate image acquisition, navigation, and interventional needle guidance, and also creating more accessible, cost-effective, and portable and patient-dedicated approaches with utility in these increased risk populations. And our lab has really generated several mechatronics and automated image-guided approaches to address this challenge, as shown by some of these illustrations here, but the predominant focus will really be on this 3D automated breast ultrasound system and also this CBIS complementary breast ultrasound approach. So one imaging modality that we leverage within our lab is ultrasound. And ultrasound, as we may know, is the most widely available imaging modality worldwide as a very cost-effective, radiation-free approach. And without diving into the physics, ultrasound involves using sound waves that propagate through these tissues to generate that differential contrast between different anatomical structures and details. And with breast imaging, ultrasound has proven highly effective for supplemental screening and diagnostic applications in clinical practice independent of breast tissue density. Additionally, it shows utility for real-time interventional needle guidance for biopsies, but also therapeutic procedures, showing clear utility for definitive diagnosis and then also guidance of treatment interventions. So this brings me to my second objective, to describe and validate this alternative wearable 3D automated breast ultrasound system for point-of-care screening. And while ultrasound offers this widely available cost-effective modality with proven supplemental screening in these women, as we may know, it's still highly operator dependent, it is time-consuming, and it lacks reproducibility for whole breast imaging for screening applications. So to overcome these challenges, automated breast ultrasound systems have been developed to enable that standardized acquisition and also multiplanar 3D visualization for whole breast assessment. However, its current implementation is still limited as these systems are relatively costly, requiring the installation of a brand new system and a workstation, and they're still not point of care, which limit its immediate bedside diagnostic utility. So how exactly can we leverage the power of conventional 2D ultrasound available in most of these clinical settings to apply them to 3D ultrasound rather than building and installing an extensive specialized system and workstation? So essentially, here's a standard 2D ultrasound image plane with standard axial, lateral, and elevational directions. And if we can acquire these images at a known geometry, specifically we use a linear scanning geometry, then these 2D ultrasound scan planes can be acquired parallel to each other at a regular fixed spatial interval. Then we can reconstruct these image planes into a voxel-based image volume, where this is a simple geometric phantom that can essentially be visualized and sliced in any direction and orientation, including multiplanar views, to localize various features of interest. So therefore, this brought us to designing, developing, and fabricating an alternative, cost-effective, dedicated 3D AVIS system for wearable whole breast 3D ultrasound acquisition and imaging. And this is essentially a wearable design with several components. So first, it contains this wearable, rapid prototype 3D printed DAM assembly that can be affixed directly onto the patient and also serves as the base to our system. Our DAM holds a sonolucent membrane, which is not shown here, to help with tissue stabilization and coupling, and also an adjustable compression assembly to help reduce tissue thickness to improve image quality in our images. It also contains this motorized 3D ultrasound scanner with an adaptable cradle, and this can be used to accommodate any commercially available ultrasound transducer for acquisition. So our 3D ultrasound scanner can be automatically translated with a simple push button to translate that transducer to acquire a 3D ultrasound image. And since our conventional transducers typically have a limited footprint width, to expand that volumetric coverage, our cradle can be shifted laterally to acquire a second image, and these are then reconstructed into a whole breast image volume that is shown here with the phantom. And essentially, this allows us to manipulate this whole breast image, and we can slice the volume in any direction and orientation, including our standard multiplanar views. So there's our transverse, our sagittal, and our coronal view planes. So just to highlight a couple of features of this wearable 3D AVIS design. So first, it is entirely cost-effective using 3D printing and also entirely economical materials for its fabrication. It is also personalizable using rapid prototyping to help conform to diverse patient geometries and sizes, which may help advance inclusive practices, but also stabilize the breast and our patient, potentially mitigating artifacts due to motion and breathing during acquisition. It also removes the need for using a mechanical tracking arm to register and track those images to develop or acquire a whole breast image. So as a newly developed system, 3D ultrasound geometric reconstruction is so critical to ensure that the acquired images are both accurate and also reliable. So we perform geometric reconstruction accuracy in a very simple 3D grid phantom, where essentially these distances between each wires represent a known nominal distance of a centimeter. So our images were acquired and we performed linear distance measurements in our standard axial, lateral, and elevational dimensions. Then we also performed phantom validation and volumetric reconstruction accuracy, which was evaluated in a tissue mimicking breast phantom. And essentially, we had spherical inclusions of 9.53 millimeters and also 4.76 millimeters in diameter. And then we segmented those volumes using an open source software 3D slicer. So just to show some of the linear measurement errors with our system. So our linear measurement errors resulted in a mean and standard deviation of 0.06 millimeters in the lateral direction, 0.05 in the elevational direction, and 0.15 in the axial direction, really showing that excellent overall linear acquisition with our system. Phantom validation was then performed and volumetric reconstruction accuracy was evaluated. And here the percent errors were also quite good. So our percent errors for the inclusions were 2.23% and also 2.11% compared to those known volumes, really showing that overall volumetric reconstruction error and reliability using our system. So we then evaluated the utility of our system in a very small proof of concept healthy volunteer studies. And to evaluate our dedicated whole breast approach, we imaged a broad range of different patient geometries and breast sizes, including a male volunteer and then also 2 female volunteers with 34A and 34F breast sizes. So really showing that range of different breast sizes. And here we developed and performed acquisition, which involved first affixing that wearable assembly to our patient. We used a very simple strapping mechanism that essentially attached onto the patient like a bra, and then put them into supine positioning. And after that, we added that ultrasonic coupling into that dam assembly to help with that coupling, where the membrane and also the compression assembly could be added to that system. Then we performed 3D AVIS acquisition, which involved approximately 20 seconds per scan. Lastly, in this proof of concept, we evaluated the effect of several variables. So the effect of the sonolucent membrane on the image quality, the effect of the compression assembly to help reduce that thickness to improve image quality, and then also its potential robustness with breathing and also motion of our patients, volunteers. So this is a dedicated 3D AVIS image in our male volunteer with our proposed acquisition and reconstruction workflow. So this male volunteer essentially helped remove complexities associated with substantial breast curvature and also tissue deformations. During image acquisition, the male volunteer was free breathing, and this resulted in a relatively whole breast 3D ultrasound image, allowing for that multiplanar 3D viewing and assessment in our axial, sagittal, and corona view planes that you can see there at the bottom row. So dedicated 3D AVIS images were also acquired in a healthy female volunteer. So this is our volunteer with a smaller 34A breast size. And this demonstration shows utility with increased curvature while maintaining that structural integrity and curvature of the breast. The volunteer was also free breathing during acquisition, allowing for multiplanar 3D viewing. However, we did observe that there was more substantial nipple or posterior shadowing artifacts in this whole breast image, which really necessitates that further evaluation within our proposed workflow. So this slide shows all 3 of our healthy volunteers, so the male and then the 2 female volunteers with 34A and 32F breast sizes in both a 3D perspective view at the top, and the bottom is a coronal view plane in the bottom row. And here we show that our dedicated 3D ABIS approach can effectively cover most of that breast volume with relatively high image quality, but we do want to compare that with gold standard methods to ensure that we're obtaining that whole breast coverage. So we also evaluated the effect of several variables. So first, the effect without and with the sonolucent membrane are shown here with this pair of images. And essentially the membrane just presents as a hyperechoic white contour around the breast, but it was also able to help stabilize those tissues while maintaining that structural integrity. It also improves modesty as the breast is entirely covered during the acquisition using this membrane method. Second, the images were acquired without and with the compression assembly, which are shown here with this sonolucent TBX plate, essentially showing that reduction in tissue thickness and also substantially improving that image quality and discrimination of different anatomical details, which is shown with this corresponding anatomical ductal structure. The effect of breathing was also then evaluated. So this top row shows the images acquired with a breath hold, and the bottom row shows images acquired with a very deep breathing from full inspiration to full exhalation to really exemplify an extreme case of breathing motion, which is also a more realistic level of motion in clinical practice than the patient moving around substantially. So while this motion did result in very small displacements in the skin and internal structures, these artifacts are still sub-millimeter, which are substantially reduced compared to normal breathing that could be up to several millimeters in clinical practice. And ultimately, this demonstrated the capability of our system to help mitigate those artifacts, since the frame of reference of the system was attached directly onto the volunteer as the volunteer breathed and as the volunteer was moving. So overall, we conceptualized and developed a cost-effective, portable, dedicated system for whole breast imaging, and we validated and demonstrated its accurate geometric reconstruction accuracy. And lastly, our small proof of concept shows the ability and utility and potential robustness to help stabilize our patient during that acquisition protocol. Our current work is focused on performing those extensive volunteer studies to evaluate different acquisition variables and parameters. And while this system demonstrates promise for improved whole breast image acquisition, it is definitely not without limitations. But specifically, one limitation to this proposed system is that although there is a high in-plane resolution, its out-of-plane resolution is quite poor due to that intrinsic resolution of conventional ultrasound transducers. And this really brings me to this complementary breast ultrasound approach. So you might still be thinking, why complementary breast ultrasound, or what is CBIS? So essentially, here is a 3D ABIS image, and this arrow shows its scanning direction. And while we see that we obtain a very high in-plane resolution due to our original images being displayed in our visualizer, there is still a poor out-of-plane resolution in that scanning direction. So intuitively, if we acquire another 3D ultrasound image in the orthogonal direction, then we would have a complementary in-plane resolution and a complementary out-of-plane poor resolution. So we really hypothesize here that combining these two orthogonal images can improve that spatial resolution uniformity by recovering that poor out-of-plane resolution from that scan direction. So how exactly do we leverage this complementary nature and improve that resolution uniformity within our image? So this is just a simple illustration of our 3D ultrasound image with multiple 2D ultrasound scan planes and an arrow indicating its acquisition direction. And there's a coronal view plane at the bottom. So this blue volume represents a craniocaudal direction acquisition with its normal pointing along the the y-axis. And here we see an anisotropic voxel based on its high in-plane and poor out-of-plane resolution. So next we acquire a second 3D ultrasound image in the orthogonal direction. So this one is performed by moving the motorized scanner exactly 90 degrees on our system with a very quick release mechanism. And this results in this orange image volume with this normal pointing along the x-axis. And since these 3D ultrasound images are defined with the same coordinate system, its in-plane and out-of-plane resolutions are complementary to each other. So now that we have acquired these orthogonal images, we can generate a 3D CBIS image. And in this combined volume, we retain that high resolution from our original image volumes in both our acquisition planes. So our blue is our first volume, and our second volume, VB in the orange. And its coronal view plane represents that average resolution between those two. Additionally, in any oblique view plane in this volume, shown as this dark purple view plane, the voxels can be computed based on a spherical weighted algorithm of the original two volumes in order to recover that resolution in our images. So without going into the specific details on our experimental results or our resolution analysis for the purpose of time and not to bore you all, I am going to show you two original orthogonal 3D ultrasound images, so A and B, and then the visual effect on our generated 3D CBIS image, so that's C on the right side. And this is a coronal view of the two image volumes of an angular wire phantom, where the best resolution is shown by that purple asterisk, which corresponds to the completely in-plane wire. And qualitatively, we see that the spread of the wires that do have poor resolution, for example, this 10 degrees and this 30 degree wire, in the original images are somewhat recovered in our 3D CBIS image. In fact, when we do resolution analysis across all of the wires, we see that the measurements in the original volumes, the full width half maximum resolutions, were 1.23 millimeters and 1.24 millimeters. And in our corresponding 3D CBIS image, we do reduce that to 1.13. And also the standard deviation is a lot more constrained, demonstrating the ability to essentially recover that resolution uniformity across our entire image volume. So in this work, we described and experimentally validated an orthogonal acquisition and also a CBIS generation approach. And this showed that our method could help improve that spatial resolution uniformity by recovering some of that out-of-plane resolution using any commercially available ultrasound transducer. And future work will focus on extensive validation in breast phantoms that represent more, that provide a more accurate representation of those anatomical structures and details, and also represent the complex breast tissue density within women with dense breasts. We also plan to perform different optimization of different acquisition parameters like frame rate and frame density, and evaluate its utility even in really low resolution transducers where this method might be more useful. So finally, I just want to really briefly discuss some key future directions and some exciting potential avenues for whole breast 3D ultrasound-based image-guided interventions with this work. So first of all, future work will start by essentially optimizing our system and ensuring that it is a fully automated system, completely removing operator dependence associated with this workflow and use. And ultimately, this would improve user friendliness, which would be essential, especially in more limited resource settings, which might not have the healthcare professionals needed to acquire these images at the point of care setting. Additionally, it would involve integrating our complementary breast ultrasound generation approach immediately into this workflow to improve that isotropic voxel resolution in our whole breast images. So finally, this developed system and the demonstration showed really establishes that foundation for several advancements with 3D ultrasound, 3D ABIS-based technologies across the whole paradigm of breast cancer screening to treatment as well. So first, we aim to implement very advanced imaging techniques such as 3D Doppler to do 3D Doppler within the whole breast volume. And this would really improve the diagnostic utility and also characterization of these breast lesions that would be detected, whether in a screening setting or a point of care diagnostic setting as well. And second, something that is interesting that could come out of this is guiding needle biopsies using our system to extend that utility to allow for definitive diagnosis immediately at that point of care. And I think that this would open up a lot of exciting avenues for image-guided needle interventions using like this template and this whole breast imaging that could be more accessible and also more cost-effective across these increased risk populations. So finally, while future studies are still required, the dedicated system, 3D ABIS system, and also CBIS generation approach shows potential towards a more alternative, cost-effective, and high-resolution approach for point-of-care imaging in these increased risk populations, especially those with dense breast or in limited resource settings. And I'd just like to thank the entire Fenster Translational Ultrasound Lab and also my funding sources in which this work would not be possible. And thank you for your time.